Drink it anyway.
But I think we should adjust things to the floor. I think.
Enough for everybody? Okay.
Our floor models have been.
Tortured with
Okay. Are you timing? Okay. I'm also happy. All right,
what am I missing?
so.
So if you guys want to just go ahead and put your needles on your, like, the little greasy situation. Oh, I need that.
So how many of you have, thank you.
Mistake for us, I did we are engaged.
Yeah, just go ahead and put the needle on there. I didn't put it on for you. Just you can discard the rest.
So this is ultrasound room. It hasn't, okay.
Just put it on the screen. Any of this? Yeah. Well, put it on the little one. It's probably easier. I'm just waiting for Alexa to come back, but maybe we'll just go ahead and start. Have any of you guys placed an IO needle before?
Yes.
In your practice? Okay, great. How was it? Successful?
Yeah, I've done some few successful ones.
Okay, great.
That's what I did last week.
That's
Yeah,
great.
Last week, yeah.
Okay, great, good. Okay, so
If you have a patient.
we use the Intraosseous needle as an option for our patients who are in extremis. This is a patient who are having a very difficult time getting an IV in, and we're going to talk specifically about pediatrics. So we're really talking about somebody who's under the age of about 7. Sometimes people go higher than 7, but the reason that we can't do it so successfully on an older, like an adolescent, without some sort of assistive device is that you're going through that really thick periostea. It's very difficult to just get through. So we've already established that this is a patient who's in extremis. You know they're very sick, and you can't get an IV line. So we automatically are going for, let's see what we have, what equipment do we have that's available. So we've got a lot of pieces of equipment that you might see in a facility that you might work at. But you should know what's available in your department, right? Isn't that always the case? You go in to help and you're like, what do we got? So what you have on your tray right now is number 1, just an 18 gauge needle hooked onto a syringe. That is something you can use, okay? Number 2, you have this Cook catheter needle. This is an IO needle. And it's interesting. It's got a stylet inside of it. Okay. I don't think those are caps, so it has a little cap. That's where the needle is. The other options that you might come across in your practice, you might see like a Jamshidi bone marrow biopsy needle. Okay, you might do bone marrow biopsies in your facility. So it has a little bit of adjustable capability, and it also has the stylet just located just back there. Okay, so you might see that. And then you might see, which is very common in like the US, is a IO drill. And it essentially looks like a drill that you're about to put your curtains up or whatever. But this is a special drill. It does have a magnet on the end of it that fits onto the magnet of the IO of the needle. Okay? Now this one, because I've used it so many times over and over, which you would not be doing, the magnet's not working so great. So we'll talk about that one separately. So those are some of the pieces of equipment we have. Do you want to jump in?
Sure.
Talked about equipment, and then we're using who's a patient in extremis.
Yes.
And a pediatric patient under the age of 7, maybe an infant.
Yes. So let's pretend this is the patient's leg. This is the size of the infant. Okay. So first, you want to make sure you have a very stable hold on the leg, okay, when you do this. So there are different ways to do it. I always take a little towel and roll it under the knee just so that it's slightly flexed and externally rotated like this. And then that creates stability for me under here, and then I can hold it against the towel and I go this way, okay? Mary likes to straighten the leg against the bed and create stability that way. What we don't want to do is hold the leg like this with our fingers back here, because the needle may go through the bone into our fingers. Not good. So you should not be behind the leg. Something else can stabilize it, okay? So the most common site in pediatrics is the proximal tibia. It's the flat part of your tibia, so you can actually feel it on yourself I think it's really helpful to feel that on yourself, a flat part.
So that's.
And you're going about 1 finger breadth or 1 centimeter below the tibial tuberosity, exactly, and on the medial side. And you go in at 90 degrees. Okay? The first thing we're going to do anytime you place a needle is clean with alcohol swab or whatever you have available to clean, betadine, chlorhexidine. You're going to take your needles. This is a special IO needle that Mary mentioned, the Cook needle. We take this cover off. And the way we hold it is like a pencil, like this. Okay? This part here creates stability against your palm. And the way we're going to insert it is just one big motion, circular downwards, while you're applying pressure. The bone is, the periosteum, the bone is quite hard, so I always kind of get on top of the patient like this and I let my body weight help me, okay? If I'm doing like this, then it's like harder to get the strength that you need, okay? As soon as you feel a give, so you're pushing against bone and then it relaxes, stop. Because if you're pushing against bone, it relaxes, and then you push again, you've gone through the other side of the bone, okay? If it's in the right place, it should be upright like this, and you just stand on its own. You shouldn't have to support it. Then you take the top off here, so you remove the stylet, and you can infuse whatever you want through the needle. You can often use one of these extenders. Sorry, this way. There's a cap on it. That's why I wrote it. Yeah, this way. And you obviously unlock it, and you can infuse through this site. Okay?
So you can flush it first.
Yes. Yes. You can also, from the bone marrow, get all your bloods, so all your labs, except the CBC may be different because you're in the bone marrow. So after you go in, take the syringe and try to extract blood, and then you can infuse as well.
The one thing I would say too is that very commonly you're in and you extract something and it's kind of just like a little bit of spray. It's not enough to send anywhere. You might get a Dexter stick out of it or something, but there's really not that much. It doesn't mean you're not in the right spot, okay? So you can go ahead and infuse the right spot. If it's freestanding, that's like the really classic sign that it's okay.
You can use any medication through an IO that you would use through an IV. But someone asked about chemo. I wouldn't give chemo through an IO. This is really meant for the medications that you use during resuscitation. So like fluids, epinephrine, dextrose, things that you would give when you're resuscitating a very sick patient. You can give blood. What's that? Yes, you can give blood.
How do you know challenges? So what is the problem? How would you do? I wonder if it was in. If it's not freestanding and it's leaning over, it's not in. If you have to support it in any way, it's not in. And that means you have to take that one out and go to the other leg, right? You can't hit it again. Because if you do it again, you're just puncturing multiple sites and the fluid will just go in and out once it starts to expand. Because what you're trying to do is access that bone marrow, that uncollapsible vein that's inside our bone, right? So that's what you're trying to get to. So it will be freestanding because you're going through the bone, and the bone will support the. So that's how you're going to say.
Yeah. No, the other thing is that this is that inside the bone marrow is higher pressure than inside a vein. So when you infuse, you will meet a little bit more resistance than you would in an IV. It doesn't mean you're not in the right place. It's just that you're in the bone marrow, okay? If you're going to give a child fluid through a system like this, IV tubing, you will need to apply some pressure for it to go in. Gravity will not be enough, okay?
Or use a syringe, use a big syringe and syringe the volume in. Yes, under pressure.
Okay. After going inside, do you need something to support it?
Good question. So you're talking about stabilizing it after it's in place.
Yes.
So what I think is really helpful is if you kind of stabilize the whole leg. And really, it's not because you need to stabilize the IO needle. It's more that you need to tell everybody in the room, do not mess with this, right? So I usually put like a patient arm hold behind it, and then I tape it to it. So even like a piece of cardboard or something, and I tape it to that. And then if my IO line is here, I'll take some tape and I'll tape it here multiple times. So if somebody pulls on the IV bag, it doesn't pull the line out. Now, in truth, we're really only going to leave that in until we get a peripheral line, right? Because it is nice because it's a large bore IV, but we really don't want to leave it in for too long because of all the risks of it getting bumped out or some other problem happening with it. So certainly within 24 hours, we would definitely recite it, but typically way before then, right? Once we fluid volume, resuscitated the patient, given some medications, they're starting to stabilize, we can find another line. So that's what we choose to do.
Yeah, back here, right?
You do this procedure under nothing? Is it not very painful for
Well,
the...
it's an important question, right? Is it painful? They did do some studies where they took Army volunteers and they jammed IOs into them. Can you imagine volunteering for that? And the report was that they felt it was as painful as an iris to go in, but once it was infusing, that's when it became painful because you've got a lot of nerves in your in that space. So that's when we talk about putting lidocaine.
So now let's go to the
So once we're infusing, we can give some lidocaine initially. Now, in truth, most of the time we're doing this procedure. This is a patient who's in extremis, and we're thinking first of saving a life, and then definitely right behind that, we're thinking about pain control. But initially, we might need to just get them some fluid. Yeah.
So most of the time when you're doing this in patients, they're
Out of it. Yes, really out of it. And there's an acronym for lidocaine
the hardest problem
adults.
Yeah.
contraction.
Which is
Remember, we're
2
still going through
cc's
liver at this point.
of
That's why you
2%
see liver on top.
lidocaine over 2 minutes,
Good.
and you do it
And
twice.
then left upper quadrant.
2 cc's of 2% lidocaine over 2 minutes, so quite slowly, and you do it twice.
Or you put a distal in the line. But the truth is, this is a sick patient, and we're really trying to get them the fluid and the meds they need. And so then the second thing, you're looking up your doses to figure out the lidocaine dose, right? First, we're starting something, and then the MRAP video that shows IO, they do talk about the formula for adults. And they show the easy IO insertion in the video. So if you look at the website, just to reinforce.
Beautiful. That's
How
very
is this one compared with
See where her shoulder
the central line? The
far down towards the bed.
You can put everything you put through a central line through an IO.
The kidney pushed up.
But the IO is much easier to use, right, and to place faster.
Yeah.
Central line, you usually use ultrasound, find your landmarks, you have the drape, the sterile technique, you know, it takes a little bit longer to place it. This one you go, whoop,
And you're giving your fluid, you're giving your meds, you're resuscitating your patient. Especially in a patient that's really sick, messing around with the central line when you've got a baby that's sick and, who knows how long that's gonna take, and nobody can bag while you're doing that. So that's another really helpful reason to have that.
So I think let's go on this side.
In terms of complications, we're
Okay.
talking about complications.
Yeah.
And we didn't talk about which site to choose. We said most commonly that we use this site here, but if you're thinking about which leg you're going to use, is there an indication or contraindication that you could think of that would make you choose one leg versus the other? Okay.
I would think less dominant foot.
Okay, that's very thoughtful. Less dominant foot, sure. The other thing that you think about is if there's any cellulitis locally, if there's a fracture. That's really important. Because if this limb is fractured, if you infuse from here, it's just going to go right back out there, right? So think about that. If there's infection, we talked about that. Or if somebody's already tried that leg, you can't try it again, right? You have to
yeah, because it's like you're poking holes in the bone. So if I poke here, if I poke a little lower, the fluid's just going to come out. So you try the other leg. You can try a site that's more proximal. So if I started here, I could try the femur, but but really, I would try the tibias first on both sides.
And just since you're on that point, the site for the femur, if you find the two condyles and then you go more proximal, right in the center there is a site there that you can use, but you're going through the quadriceps muscles there, so it's going to be thicker and a little bit more difficult. So this is a super easy, babies come in, they're externally rotated, like they're offering you that site here, put this in me. So that makes it a lot
So
easier.
for the femur, is there a specific distance you have to measure from the condyle?
We always talk about 2 finger breadths, don't we? Yeah, 2 finger breadths. So you find, it's really where the condyl's narrow.
You're
and
actually
right
seeing
finger. Yeah.
How,
And you're trying to avoid the growth plates. Growth plates are present right in this area as well as, in your femur. So you're trying to avoid those spaces. Now, there are studies where they deliberately injected those spaces in pigs, and they didn't find that it had any long-term effects. But clearly, that's not what we're trying to do. So that's why we're going a little bit distal to avoid that.
Okay, apart from the tibia and the femur, any other bone
We're
that you be
looking
doing?
for black.
You can do it on the medial malleolus, or above, 1 centimeter above the medial malleolus. So this piece, you go 1 to 2 finger breadths above, and you can try there. It's not as easy to find, I think. Like when you feel here, you're like, oh, it's a really flat surface. It's very close to the skin. This is really the preferred site, but you can try the other two.
Okay.
And sometimes people will also use the proximal humerus. Yes.
Like not
Oh,
commonly.
which ones do you like black?
Not
Not
Yeah.
commonly. Anywhere there's bone marrow, theoretically you can do it. You can do it in your Intraosseous, but what a pain it would be to be resuscitating somebody with a needle coming out of their back. So you're not going to do that.
Yeah, this is the preferred site.
Doesn't matter.
Yeah. Okay.
Either way.
So you want to get? Should we get started?
Alrighty.
Yeah, should we get started? The other thing, do you want me to get
Alright, so.
Oh, I got it, yeah.
Complications here.
Oh, sure. Complications. I got it though. So the complications, number one, is infiltration. So if you went through the periosteum on both sides, for example, you could infiltrate behind in this little pocket back here.
so you're always going to feel that posterior tibial compartment after you've placed it. You just want to make sure it's soft at the beginning. So then later, if someone's like, oh, the line's not working so well, you just feel back here. It'll feel firm. You'll know you'll know if you've extravasated back there. You'll feel it filling out.
What's that?
So that's one of the complications that you're concerned about. We talked about infection. The infection rate is about the same as an IV for the first 24 hours, so that's not really so much of an issue. And then there's like a little bit of a bone abnormality that will show up still on X-ray for about the next month. So that's just something that you know.
How long do you keep it in place?
We only keep it in place until we can recite it. So really, you can theoretically keep
Just
it
go under the subxiphoid, CIT liver,
problem, but you really want to recite it as soon as you
So
can.
just go subxiphoid and then just rotate up.
I think if there's anything else.
I think those are the major points. Oh, did we talk about the drill?
Yeah, I can show you the drill, and you guys are welcome to try it later with some clean gloves or no gloves. Again, it's magnetic. It's a drill. So there's different brands of drills. This one's called an Easy IO. It's a little bit smaller. The handle is. It has a lithium battery that you can recharge, which is handy. These are all sterile. Obviously, I've been reusing this one, but these would be sterile. And then you just place it onto the shaft, and when you haven't been reusing the needles, it really does click on really nicely. This one I've reused, and then I'm gonna take off my off my cover. I'm gonna clean off with some saline, right? And then for this one, you can actually push through.
There we go.
This skin example is very deep. It's not like that in a human, right? You wouldn't be using that deep of thing. You can go ahead and push through, and then you don't have to start drilling until you're through the skin. And then you can go ahead, and you'll feel the pop in a real person. And then you can go ahead and take this off. And then this, and of course it's freestanding. I like to hold on to my line as I maneuver it, just so I don't knock it out. And then the same thing that we talked about, you suck up some, blood or do whatever, hook up the eye. Okay, so these are very expensive drills so you see them intermittently. Certainly in North America, you see them a lot emergency departments will stock them now, but they're costly. So there you go. And in taking out an IO, it's just really simple too. You just twist it and pull it out. And then obviously you don't reuse a needle, but I am today. So on your plates, you have an IO needle, a Cook IO needle, and then you just have a plain 18-gauge syringe, and you have a chicken leg. And now with the chicken leg, I don't know chicken anatomy, so good luck. Just find a flat surface on the bone, like poke around and just lay it on the thing. Just find a flat surface that you were going to try. Like you'll feel the resistance.